This episode of GT the Podcast is supported by Alcon. Hello, and welcome to a special edition episode of GT the Podcast. Today, Dr. Blake Williamson leads an expert surgical panel of Drs. Debbie Ristvedt and Mark Gallardo to discuss their experience with the iStent Inject W device and why they chose it as their go-to MIGS device. They cover key features of the device, clinical data, and how the device helps surgeons easily combine cataract and glaucoma surgery.
Hello, this is Dr. Blake Williamson from Williamson Eye Center in Baton Rouge, Louisiana. I am a cataract and refractive surgeon and also specialize in minimally invasive glaucoma surgery. And that's the topic of today's podcast. We're going to spend the next 15 minutes talking to two surgeons who I respect very much. And I'm very excited to get their perspective, not only with their current MIGS algorithm, but specifically learn more about how they use iStent Inject W in their practice. We're joined today by Dr. Deb Ristvedt from Alexandria, Minnesota, as well as Dr. Mark Gallardo from El Paso, Texas. So Deb, I'm going to start with you. With all the different MIGS options out there today, where do you start? It seems like that's one of the biggest questions that people have is, what's your go-to in terms of if you have just one that you're going to get started with and maybe why?
Yeah, so, MIGS has grown, it's exploded, and we have more options than ever. And when we started, 11 years ago, there weren't as many devices or options. And so the progression was pretty natural for me. I started in the angle and continued to build. And now the algorithm is really an art. How do you decide what device you're going to use or what technology you're going to get started with? And as a cataract surgeon, I love starting in the angle. It's so natural. And we're trying to really optimize that outflow pathway and in a safe and effective manner as well. And so my go-to for mild to moderate glaucoma, in addition to cataract surgery, starts with the iStent Inject W.
And Mark, you're well known as one of the foremost glaucoma experts in the country, and I know you do a tremendous amount of surgery. Do you agree that really the angle is where we need to be starting? And if you're going to be doing cataract surgery, the stenting is kind of where you start as well, or how do you decide what to do first?
It's very similar. Of course, it is multifactorial, but when we're talking about combining a glaucoma procedure with cataracts in mild to moderate patients, it really does make sense to add a procedure that doesn't really add any additional risk or recovery to the cataract surgery itself. And it's really one of the big reasons why we're now coupling cataract surgery with glaucoma surgery in almost all patients that have both diseases at the same time. 15 years ago when I was doing my training, would never fathom performing a trabeculectomy on a patient with mild disease on one medication that was stable. It just didn't make sense. That risk-benefit profile didn't make sense. But now, because MIGS devices and procedures are so incredibly safe and effective, we're adding that to just about every patient that's going into cataract surgery that has glaucoma on medications. And starting with the angle, of course, is the most effective means of managing a patient. And like I've always said for many, many years, I like to start with procedures that leave the smallest footprint on the eye. And of course, the iStent Inject W with its small size and proven efficacy is really one of the first line treatments that I go for as well.
Yeah, and I would agree. I think that, for me in my practice, a lot of times my favorite MIGS procedure is the one that I can do the best. And with the original iStent, for some surgeons at least, there was a longer learning curve. But I find that with the Inject W, actually, it was a much shorter learning curve for me, and I feel very confident that I'm getting 2 stents in every single time. And there's a lot of different features that make it, in my opinion, have that shorter learning curve. Dr. Ristvedt, was there some highlights or benefits of the W that stood out to you whenever you added it to your practice?
Yeah, I really love that it has a wider flange because there's less room for error in bearing the iStent. So with the iStent Inject, which had two stents, if you dimpled or pressed a little too much, you could actually bury that iStent. And now with the iStent inject W, it's really hard to do so. And so it's a lot more predictable when it comes to placing the iStents in a proper manner, 2 clock hours apart, and not burying that stent into Schlemm's canal.
And Dr. Ristvedt, I know that like me, you do a lot of premium cataract surgery, and patients are all about that visual outcome, like that post-op day one. You can't mess with that visual outcome. Is that another huge benefit? And do you feel comfortable pairing the iStent inject W with toric IOLs or presbyopia correcting IOLs?
Yeah, now the data speaks for itself. We know that as far as safety goes, cataract surgery versus cataract with iStent inject W is just as safe. There's no added risk. And so that was really, one thing that stood out to me when looking at the data. I like to call minimally invasive, minimally disruptive when we're talking about premium IOLs and adding a minimally invasive glaucoma surgery, because nowadays patients want to get back to normal routines, normal activity, and see well after premium IOL technology. And so when you pair it with a device where it's going to be minimally disruptive to that vision, and the risk profile is no more than just cataract surgery alone, the combination speaks for itself.
Yeah, and I think that for many docs are probably like myself, that what is minimally invasive has changed a lot. Back in the early days with generation one, anything that was not a tube or a trab was considered MIGS, right? And so I've learned from Dr. Gallardo and others that there's actually there's varying degrees of what's minimally invasive. Mark, what about the data? I mean, there's other great MIGS products that are available, but I would argue that none of them have the volume of data in terms of the amount of published literature out there compared to what Glaukos has done.
Yeah, when you think about MIGS, you automatically think about the iStent and the iStent inject and the whole Glaukos portfolio of devices. They're the first market. The thing that as a glaucoma surgeon that I look at is the number of adverse events that have been reported for different devices and different procedures. And we talked about the wow effect for our post-op cataract patients. And we, in addition to having an excellent efficacy profile, we know that it's astigmatically neutral. So it doesn't add any additional curvature or change to that corneal astigmatism. But the other thing you want to talk about is what the anterior chamber looks like in the postoperative period. Because if you're doing a larger procedure, you might have a little bit more tendency to get a little bit of blood regurgitation into the anterior chamber, which can affect postoperative day one visual acuity. And of course, you do have that risk for developing some recurrent hyphemas for the larger procedures that remove larger strips of the trabecular meshwork. But there's so many peer-reviewed papers in the medical literature, both retrospective, prospective. We have our pivotal trials that have proven time and time again that the Glaukos platform, starting with the first generation iStent through the iStent inject W, are very effective. But of course, it's not the only, or they're not the only products that are in the pipeline. What's exciting about the Glaukos platform, we're now on our third generation iStent, but it's a company that continues to innovate, and there's a lot that's in the pipeline. We do have the iStent Infinite, which completed its pivotal trial, and they were able to report on the 1-year data that showed wonderful efficacy in patients that had refractory glaucoma. What's nice about this study is that it was done as a standalone procedure in patients that had refractory glaucoma. 70% of those patients had previous glaucoma procedures, whether it was a trabeculectomy, a tube, or SLT. They were phakic or pseudophakic. And it gives us that different avenue of managing the angle without performing an ablative procedure as a standalone procedure. But they also have the iDose, which they reported on their 2-year efficacy. And so when we talk about implanting a device, potentially taking a patient to the OR, we want to make sure that that device is going to last a while. And they were able to show that the iDose, which is a travoprost containing canister, was proven to be effective through 2 years at the very least. But they have other products on the market. The iDose TRX is a similar size canister, but it has double the amount of medication. There's a potential for having a Rho kinase inhibitor within that canister in the future. One thing that, you know me, I always like to talk about viscodilation. And so they've been working on developing a new product called iPrime. And then of course we have for those patients with severe glaucoma, we have the PreserFlow, which is already completed their clinical trial. And I think we're just waiting for the FDA to give us a thumbs up for that to come to market.
Yeah, and for a company that is constantly investing in R&D in their pipeline, it's not surprising to hear about all those amazing technologies that have come out, especially, when you already have great data for what they have now. There's been meta-analyses recently done showing multiple years of efficacy with standalone stenting that Glaukos is with the Glaukos iStents. So, Dr. Ristvedt, you just heard Dr. Gallardo talk about all the different things coming in the pipeline. Do we still need to wait for those things, or should we still be kind of hanging around? Or, for those people who are ready to get started now, do you think now's the time? And is Inject W something that they should consider starting with?
I think now is the time. My journey started right off the bat, getting out of residency, being in my first year of practice. And I am so glad that I took that leap, because the amount of individualization I'm able to provide to our glaucoma patients now is great. And to be able to have so many options is wonderful. And really, if you're just getting started and looking at minimally invasive glaucoma surgery and how to add it to your practice, or if you're looking to expand, we have other products down the pipeline that are coming. And this is here to stay. Minimally invasive glaucoma surgery is here to stay. And you even see that with drug delivery devices that, Mark just talked about. And so if you're getting started, start with your cataract patients, just like we did in residency, where we started with incisions. We had to have good incisions to complete the case. Every step counts. And so visualization is key. And so when you're in the operating room, go ahead and get started with tilting the microscope and tilting the head of the patient to really get down the setup. The setup is key to be able to view the trabecular meshwork and to view that angle. You want to view it head on. And so you don't want to attack the angle from above. And so that's just going to help with success when working in the angle. And then make sure that you can visualize the trabecular meshwork. As we know, some angles don't have a lot of pigment. And so being able to really identify that trabecular meshwork is going to set you up for success. And just keep practicing. Make sure that you get a multiple amount of patients at once. And so if you have multiple patients in a row where you're practicing and you get that muscle memory down, it becomes easier in your hands over time. But nothing's easy from the get-go. We have to start somewhere. And with knowing that this is such a safe and effective device, this is really a place to get started and to build as you become more comfortable.
Yeah, and I think that I always like to say that glaucoma is the new astigmatism, and if you're already there, for us, if the refractive guys and gals listening and the general ophthalmologists, of course, you're going to give the patient an option to treat astigmatism. Why wouldn't you do the same thing for the glaucoma? And from a practical and business management standpoint, we're having all kinds of issues with reimbursement with cataract surgery. Here's this whole other avenue that could actually be a practice builder for you. But more importantly, it's the right thing to do. And I have to say, it's a lot of fun too. Getting patients off of their drops is wonderful. And oftentimes they're happier with that than they are getting out of their glasses, believe it or not. So it's been a fantastic wave to ride over these past 5 years. And I really appreciate you guys coming on and sharing your experiences. And thank you for listening.